So, namaste all. So, good evening and inviting you all for today's fourth day of a rapid review program. Today's faculty is Dr. Yogalakshmi ma'am, who is Associate Professor of Pathology, Coimbatore Medical College. Ma'am will discuss about the second part, hematology part of pathology. Inviting ma'am, we'll start with the Om Mantra thrice and NMO mantra. I'll recite. Om. न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवम् कामये दुःखतप्तानां प्राणिनाम् आर्तिनाशनम्. Om. Yes, ma'am. You may please start the meeting.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Good evening, everyone. I hope this session will be useful for you. So, today's my topic will be hematological. Few topics I will be covering because of the huge volume of the session. Topics I will share few lymphoid, myeloid, and few anemias we will see today. So basically, coming to the first, we will see the lymphoid neoplasms. First, we will see this is the structure of the lymph node, bone marrow, and thymus. What is the connection here? So the bone marrow produces the basic hematopoietic cells. There we have a myeloid lymphoid cells. These lymphoid cells, we have two types. One is the B cells and another is the T cells. These B lymphoid cells, they get maturation in the bone marrow itself. Then after maturation, they come to the lymph nodes. The T lymphocytes, they get the maturation in the thymus. After the maturation in the thymus, they come originated from these type of cells. Mature cells like plasma cells or marginal cells or germinal center cells. So from the precursor naive cells to the mature cells, all the lymphoid neoplasms are getting from the origin. So we can see the precursor cells, they give the B lymphoblastic lymphoma, and from the naive cells we can get small lymphocytic leukemia or lymphoma CLL or bar SLL. From the plasma cells we can get multiple myeloma. Coming to the lymph node architecture, we have a germinal center. Surrounding the germinal center, there will be marginal zone will be there. Surrounding the marginal zone, there will be mantle will be there. So mantle will be surrounding these things, and then marginal zone will be there. So coming to the germinal centers, the neoplasms arising in the germinal centers are follicular lymphoma, Burkitt's lymphoma, diffuse large B-cell lymphomas, and Hodgkin's lymphoma. So the mantle zone give rise to mantle cell lymphoma, and the surrounding marginal zone give rise to marginal zone lymphoma. These are the origin of the B neoplasm, B side of B cells of the lymphoid neoplasms. Coming to the T cells, we have if the neoplasm or a lymphoma arising in the precursor cells, that is called as the T cell ALL, and if the lymphomas arising in the mature cells, that is the so the immature B cells, they give rise to the acute lymphoblastic leukemia or lymphoma. Either it can be a B cell or it can be a T cell. Coming to the mature neoplasms, we have so many mature neoplasms like Burkitt's lymphoma, diffuse large B cell lymphoma, extranodal marginal zone lymphoma, follicular lymphoma, hairy cell leukemia, mantle zone lymphoma, plasmacytoma, CLL. So this is the origin. They have given the origin where the lymphoma is produced and what is the genetic mutation producing these lymphoma T cells or NK cell lymphomas or lymphomas. They are adult T cell leukemia or lymphoma, peripheral T cell anaplastic large cell lymphoma, extranodal NK T cell lymphoma versus fungi Sézary syndrome, large granular lymphocytic leukemia. So many NHL lymphomas are there. We will see only lymphoid or myeloid. So these two lines will be produced from the myeloid. We will be having a myeloid with a myeloblast and mono derivation. And then megakaryocytic and erythroid, they will be dividing and they will produce the erythroid cells and megakaryocytes. From the lymphoid cells, it will be dividing as a T cell and B cells. So from the initial stem cells and then committed next will be the committed progenitor cells. From these committed progenitor cells, with the help of the CD34 and all the erythropoietin, thrombopoietin or growth factors, so many colony stimulating growth factors, interleukins, they make the maturation of the progenitors and make they finally the matured myeloid and the monoblast seen in the peripheral smear. So from the and
Ma'am,
immunoglobulins, cytokine, yes.
ma'am, your screen is not visible, ma'am. Try to share your screen again, ma'am.
Yes. Is it visible?
No, ma'am.
It's coming now.
Yes, ma'am. Yes, ma'am. It's visible now,
Yes,
ma'am.
thank you.
Please continue, ma'am.
Yes. So we need many transcription factors, immunoglobulins and cytokines for the differentiation and maturation of the cells from the progenitor cells to the mature cells. And then during this maturation process, these cells they gain the cell surface markers, which are also called as a cluster of differentiation. CD is a cluster of differentiation. So from the progenitor cells, from the precursor cells to the mature cells, in each some kind of CD cells will be going in manifesting in the those cells. So these go for an investigation. CD10s and CD19, all the CD markers will be used, and we can identify which is the lineage, which is the cell of origin of this lymphoma leukemia. So this is the help of this cell surface markers. So first we will see the acute lymphoblastic leukemia by lymphoma, which is an neoplasm arising from the precursor B and T cell origin. So it is a neoplasm arising from the immature pre-B or immature pre-T cells. Like this means the T cells are getting matured in the thymus. The B cells are getting matured in the bone marrow. So thymus is maximum in size in the adolescent period. So the usual these presenting in the adolescent male in the as a thymic lymphomas, and usually they will be associated with the lymph node and spleen enlargement. Usually they are the childhood leukemias. Acute ALL is the childhood one. So adult in adult, B and ALL are less frequent in the adults. So what is the pathogenesis producing the acute lymphoblastic leukemia? So there will be expression and function of transcription factors. These transcription factors dysregulation required, this dysregulation leads to dysregulation. They will be usually these factors will be transcription factors will be required for the normal B and T cell development. So whenever there is a dysregulation, they produce the leukemia. So what is the abnormality, genetic abnormality? TAL, 70% of the TAL, they will be having the mutations in the NOTCH1 gene. So gain of function in the NOTCH1 gene will be seen in the
Hello, ma'am. Hello.
and this is a
Hello, ma'am.
active tyrosine kinase. So these genetic mutations, they produce the blast cells to proliferate, and there will not be any maturation. So the blast cells will be accumulating within the bone marrow. So the bone marrow will be having hypercellular, and they will be having so many
Ma'am.
lymphoblast. So it can be a B or T cells. What is the morphology of the lymphoblast? Usually the lymphoblast will be having a granular and a scant basophilic agranular cytoplasm, and then coming to the nucleus will be having a condensed chromatin, and nucleoli, it can be inconspicuous, or we can see one to two
Hello,
nucleoli.
ma'am.
The nuclear membrane will be subdivided with the
Hello.
convoluted appearance, the lymphoblast. So we have to see the morphology. They will be asking what is the difference between the lymphoblast and myeloblast. Coming to lymphoblast, the lymphoblast will be having a scant basophilic cytoplasm. Chromatin is condensed. Nucleoli will be 0 to 2, and nuclear membrane will be deeply subdivided, producing convoluted appearance. Sometimes if the proliferation is so much, means due to the increased proliferation turnover, there will be more amount of apoptosis, so it can produce a starry sky appearance. But this starry sky appearance, if they ask about starry sky appearance, first lymphoma to come in mind is the Burkitt's lymphoma in a childhood period. So here also, if there isn't more proliferation, produce a starry sky appearance. So coming to the special strain, how we can diagnose the lymphoblast. The special strain, the cytoplasm will be
Ma'am,
having a
excuse me, ma'am.
PAS block positivity and
Hello, ma'am.
yes, yes,
Ma'am,
Keki.
ma'am, your screen is not visible again, ma'am.
Okay. மாமா அங்க வந்துரும் அங்க நெட் கொஞ்சம் நல்லா இருக்குமா நெட் வர மாட்டேங்குது
Yes, ma'am, it's visible. Please continue.
So we have to see what is the difference between the lymphoblast and myeloblast. So first picture is the lymphoid cells lymphoblast. Next one is the myeloblast. We can see minimal amount of cytoplasm with a darker chromatin and nucleoli is not that much conspicuous. This is the lymphoblast has one, two nucleoli, coarse chromatin, and more basophilic without any axonophobic granules. There is no be expressing the terminal deoxynucleotide transferase, that is called as a TDT. So when we put a marker TDT is present means it is an ALL. And also if it is an B cell origin, these B cell ALLs, they will be showing the positivity for the CD19, PAX5, CD10, CD20 and mu chain. If it is an origin from the T cell ALL, these cells will produce the positivity for CD1, CD2, CD5, CD7, CD3, CD4 and CD8. So this is the immunophenotyping. Through the immunohistochemistry, we can identify the lineage of the ALL. So coming to the clinical features, so many blasts are produced and it is an acute one. Immediate, the sudden breakdown will be there. So it produces few weeks itself, the symptoms will start. So what is the symptoms? All the blasts, they occupy the majority of the bone marrow. So the normal functional platelets, they will be producing bleeding. So these are the manifestations: fatigue, fever, bleeding. Sometimes on the what is the characteristic of these ALL cells? So these lymphoblasts, they will be going in infiltrating other organs. So the main organs, first is the bone. The marrow expansion, these blasts, they will be expanding within the marrow and then they will infiltrate the subperiosteum. They will produce the bone pain. Apart from that, the lymph nodes, spleen.
Excuse me, ma'am.
Yes.
Ma'am, I think you have a very weak signal, ma'am. Again, its screen is disrupted, ma'am.
Can I join in phone?
Yes, ma'am. Yes, ma'am.
I will try.
I've shared it to your WhatsApp too, ma'am.
Yes, I will try to join in. ஃபோன்லேயே பண்ணல இதாகிட்டே இருக்கு.
கட் ஆயிடுச்சு அது இல்லை ஃபோனில் அது போட்டால் அது நேராக இருக்காச்சு மெயில் ஸ்டார்ட் பண்ணு குட் பெயிண்டிங்க பேசு
வீடியோ வருதா? ஸ்க்ரீன் தெரியுதா?
இல்ல மேம்.
ஸ்க்ரீன் தெரியுது.
ஹலோ
ஹலோ மேம். மேம்.
ஹலோ
எஸ் மேம்.
ஃபோனில் எதுவும் வருதா?
இல்ல மேம், ஸ்க்ரீன் பிளாங்காக தான் மேம் இருக்கு.
அதில் வரலாம் கேளு.
ஷேர் ஆப்ஷன் ஒன்று இருக்கும் பாருங்க மேம், அதில் ட்ரை பண்ணுங்க மேம்.
அது ப்ராப்ளம் கனெக்ட் பண்ணாது. இங்கே வச்சு தட்டு. இங்கே வச்சு தட்டிட்டு அப்புறம் ஷேர் பண்ணு. ஸ்க்ரீன் வருதுன்னு பார்த்து.
Yes, ma'am. It's visible now, ma'am.
Okay.
Yes, ma'am.
So the ALL, they will be infiltrating the bone, producing a bone pain. Apart from that, the ALL cells, they will be going and infiltrating the testis, producing a testicular enlargement. And the TALL, because they are produced in the mediastinum, they are seen in the mediastinal region, they will produce the compression of the large vessels and airways in the mediastinum. When the ALL cells, they infiltrate the meninges, they produce the headache, vomiting and nerve palsies. So meningeal spread can be there. These are the clinical features of the ALL. Coming to the prognostic factors, we have a favorable prognostic factors and worse prognostic factors. What is the favorable means? If the age group is 2 to 10 years, or if the patient is having a low white blood cell count, hyperdiploidy or trisomies in the 4, 7 and 10 chromosomes, presence of T translocation 12, 21, all these are the favorable prognostic factors. And when the patient is age is less than 2 years, or if the patient is having a KMT2A gene, or the patient is having CNS involvement, it has a worse prognosis. And if the patient is presenting in the adolescent age group or adulthood, or if the peripheral blood blast count is more than 1 lakh, or if we see the molecular detection of residual disease after the treatment, all these are worst prognostic factors. So what is the treatment for the ALL? So most of the treatment, aggressive conventional chemotherapy will be given, and 95% of the remission will be there, and 75 to 80% will be cured. And we can specifically targeted therapy like BCR-ABL inhibitors can be given, and sometimes chimeric antigen receptor T cell against CD19 can be used for the treatment. So we have seen about the acute lymphoblastic leukemia. Then we will see the chronic lymphocytic leukemia, or CLL/SLL. So what is the age group here? The elderly patients of 60 years, usually mean age is 60 years, males are commonly affected. What is the difference between CLL and SLL? If the malignant cells, they involve the tissue that is called as a small lymphocytic lymphoma, and if the malignant cells, lymphoid cells, they are seen in the peripheral blood and marrow, that is called as the chronic lymphocytic leukemia. The later stages like spleen, lymph node and liver will be enlarged. The absolute lymphocyte count should be more than 5000 per millimeter square. So what is the pathogenesis to produce the CLL/SLL? So it is a slow growing indolent tumor. So the cell survival will be more here. Apoptosis will be reduced and the cell survival will be more, and some amount of immune dysregulation will be there. So for the increase in the cell survival, there will be deletion of the 13th chromosome. So deletion of 13th chromosome, it will be produce a deletion of the microRNAs 15A and 16-1. These, due to these deletion, these will produce the BCL2 upregulation. So BCL2 upregulation, this is the anti-apoptosis. So there will be more amount of tumor cell survival. Also gain of function the Notch1 receptor and NFK beta mic pathways, they will also be stimulated to produce more amount of cells. And BTK gene loss of function mutations produces immune dysregulation. So all these genetic abnormalities, they produce the CLL/SLL. So it is a B cell neoplasm. So what is the immunophenotype here? All the B cell markers like CD19, 20, 23 will be positive with a surface immunoglobulin BCL2 and CD5. So coming to the morphology of the CLL/SLL. So I told you CLL is a peripheral smear blood disorder, and SLL mainly affects the tissues. So in the lymph nodes, the lymph node architecture will be completely effaced by the small lymphoid cells, small lymphocytes. These cells usually they are small, round to slightly irregular nuclei will be there with the condensed chromatin, scanned cytoplasm will be there, and these will be looking like a small mature lymphocytes. And then few activated large lymphocytes will be there. If the large lymphocytes, they produce a loose aggregates with the mitotically active cells. These are called as the proliferation centers. So these type of proliferation centers can be seen in between the tumor cells. So this is a small proliferation center. Coming to the CLL, it is seen in a disorder in the peripheral. We can see the lymphoid cells, the malignant cells in the peripheral smear. So here we have to see the absolute lymphocytosis, and then all the cells will be seen as a small mature looking lymphocytes. These cells are very fragile. So when we prepare the smear, these cells will be ruptured, the cytoplasm will be ruptured, and they produce a smudge cells. So numerous smudge cells will be seen in the CLL. So the first picture shows the tissue malignant cells. This is an SLL, and the next picture shows the peripheral smear produced, so showing so many mature looking lymphoid cells, and we can see so, irregular cells. These are called as the smudge cells. Coming to the clinical features of the CLL bar SLL. So due to the narrow displacement of the normal marrow elements, all the anemia, neutropenia and thrombocytopenia, mature cells will not be there. So these symptoms will be present. We can see these symptoms, and the patients can be seen with the lymphadenopathy and hepatosplenomegaly. The leukocyte count, yes, in CLL, the count can be mild increase or it can exceed up to 2 lakhs. And due to the immune dysregulation, there will be hypogammaglobulinemia, and also autoimmune hemolytic anemia and thrombocytopenia will be associated. This CLL bar SLL is an indolent slow growing tumor, but sometimes it can transform into a more aggressive tumors like a prolymphocytic leukemia or diffuse large B cell lymphoma. If it becomes like an diffuse, if it transforms into diffuse large B cell lymphoma, this is called Richter syndrome. So this is about the CLL bar chronic lymphoid malignancy, CLL bar SLL. Next we will go to the plasma cell neoplasm. So the plasma cells, they come from the germinal centers, mature from the germinal centers, and they will be seen as a plasma cells. The neoplasm arising in these plasma cells, they are B cell proliferations, and then the main characteristic of the plasma cells, they secrete the immunoglobulins. So here neoplastic plasma cells, they will secrete the monoclonal immunoglobulin, complete or fragment of the immunoglobulins. So the blood, in blood, we see a monoclonal immunoglobulin. This is called as the M component. Sometimes these neoplastic plasma cells, they can synthesize only the light chains along with the M component, or only the heavy chains. The free light chains, they are very small size. These small sized free light chains, when they are excreted in the urine, we can see the proteins as an Benz-Jones proteins. So the main lesion in the multiple myeloma is the bone lesion. So the plasma cell neoplasm, they will produce a lytic bone lesions. Due to that, hypercalcemia, renal failure and acquired immune abnormalities will be seen. Here the bone lesions will be dominating. In the later stage, lymph nodes and other sites can be involved. The multiple myeloma, the age group commonly affected is the 65 to 70 years. So here also, what is the genetic abnormality producing the multiple myeloma? Here, gene rearrangement in the IGH locus on chromosome 14q32 and other proto-oncogenes, they produce the genetic abnormality. Here the rearranged genes like cyclin D1 and cyclin D3 in the chromosomes 11 and 6 can be dearranged, and deletions of 17p, and in aggressive late stages involvement of MYC and NFK beta to support the B cell survival, all these are mutated. And one more thing is the interleukin 6. This is a growth factor which helps the plasma cells to proliferate. So this growth factor interleukin 6 will be produced by the tumor cells itself or the surrounding marrow cells, the stromal cells, they will produce this interleukin 6. So coming to the bone part, so the bone myeloma cells, they produce a chemokine called MIP1 alpha. So this produces a stimulation of the osteoclast formation and increases the osteoclastic work. And modulators of the WNT pathway, they produce the inhibition of osteoblastic function. So decrease in osteoblastic function and increase in the osteoclastic function, they produce increase in the bone resorption. So bone resorption produces a hypercalcemia, and finally pathological fractures can occur. So So what are all the bones? Mainly the axial skeletons will be destroyed here. Vertebral column, ribs, skull, pelvis, femur, all these bones are the in decreasing order, they will be affected. So first initially the lesion will myeloma cells will be originating from the medullary cavity, then they will erode the cancellous bones, and finally they produce the cortical destruction, producing pathological fractures. When we see in the X-ray radiologically, we can see the punched out defect with a 1 to 4 centimeter diameter of a soft gelatinous red tumor masses. So in the marrow, we see more number of plasma cells. They constitute more than 30% of the cellularity, and in the pattern how they will be arranged, they will be infiltrating the interstitium, or they can completely replace the normal marrow area. And what is the morphology of these malignant plasma cells? They will be having the eccentrically placed nucleus. So nucleus will be eccentrically placed with a perinuclear clearing due to prominent Golgi apparatus seen in the malignant plasma cells. Sometimes their precursor like plasma blast with vesicular nuclear chromatin, single nucleolus can be seen. So due to the immunoglobulin secretions, these are the dysregulated synthesis and the secretions of these immunoglobulins. These immunoglobulin proteins or inclusions, they will be seen in the cytoplasm of these malignant plasma cells. So if the cells, they produce a fiery red cytoplasm, if the cells contain the fiery red cytoplasm due to the intact or partially degraded protein, this is called as the flame cells. Or if the inclusions are, these proteins are seen as in multiple grape like cytoplasmic droplets, they produce a Mott cells. And then sometimes inclusions can be seen like a fibrils, rods, or globules. If the globules are seen within the cytoplasm, they are called as the Russell bodies, and the globular inclusions in the nucleus, it is called as the Dutcher bodies. So microscopically we can see Russell bodies, Dutcher bodies like that. In advanced stage, the plasma cells will come out of the marrow and they will be infiltrating all the spleen, liver, kidneys, all other organs will be involved. So due to the increase in the high amount of M protein, these M protein, they will allow the cells to red cells to stick to one another in a linear fashion. That is called as a rouleau formation. Due to high levels of M protein, there will be increased rouleau formation in the multiple myeloma. So what are the features, clinical features? The patients will be having a pathological fractures with the chronic pain due to hypercalcemia coming from the bone erosion, eroded bone, confusion, weakness, lethargy, constipation, polyuria, and the kidney dysfunction will be there. And due to the abnormal or a decreased immunoglobulins, there will be recurrent bacterial infections can be there. When the Bench Jones proteins free light chains, they go on excreted in the kidney, they are very toxic to the renal tubular epithelial cells. So they produce a myeloma kidneys. Sometimes light chains in the lambda 6 and lambda 3 families, they can produce a amyloidosis of the AL type. So this can produce a soft tissue deposit, or kidney dysfunction can be produced due to this light chains also. So here M protein should be more than 3 gram per deciliter in the serum, or the light chain should be more than 6 gram per deciliter. It also produces, it has a Crab criteria. So to tell it is in multiple myeloma, the Crab criteria is there. So this is hypercalcemia, renal dysfunction, anemia, and bone lesions. So what is the immunophenotype for plasma cells? One is the CD138 and next is the CD56. So the treatment comes as an bisphosphonates, proteasome inhibitors, thalidomide, and hematopoietic stem cell transplantation. So this is about the plasma cell neoplasm. Next is the Hodgkin's lymphoma. So all these topics are coming under the non-Hodgkin's lymphoma. Next we will see the Hodgkin's lymphoma. It is a group of lymphoid neoplasm. The Hodgkin's lymphoma arises in a single node, or it can come from a chain of nodes. Usually it spreads in anatomically contiguous areas. So we have two major types. One is the classical form of the Hodgkin's lymphoma, and next is the nodular lymphocyte predominant Hodgkin's lymphoma. Coming to the classical type, we have four subtypes like nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted Hodgkin's lymphoma. So what is the main neoplastic cells in this Hodgkin's lymphoma. The main neoplastic cells name is the Reed-Sternberg cells. They are mainly produced from the derived from the germinal center or post-germinal center B cells. These neoplastic Reed-Sternberg cells, they release many factors. These factors, they go and accumulate the reactive lymphocytes, macrophages and other granulocytes around these RS cells. So the main tumor, the Hodgkin's lymphoma, when we see in the peripheral smear, we see RS cells along with the so many reactive cells. So the reactive cells, they make up the 90% of this tumor cellularity. What is the classical type? The classical immunophenotyping of the classical subtype. The PAX5, CD15, CD30 markers are useful to identify classical subtype of Hodgkin's lymphoma. So what is the genetic abnormality producing the Hodgkin's lymphoma? So the NFK beta is needed for the proliferation of lymphoma. So here the activation of the NFK beta is the EBV infection and rel proto-oncogene, they increase the NFK beta activity, they produce the neoplasm. So this picture shows the Reed-Sternberg center Reed-Sternberg cells producing so many chemokines and cytokines. They produce they attract the other reactive cells around the tumor cells. So the main neoplastic cell is the Reed-Sternberg cells, but the apart from this main Reed-Sternberg cell, we have some other variants of the Reed-Sternberg cells like mononuclear Hodgkin cells, Lachner cells, popcorn cells. All these cells are seen in different subtypes. The main tumor cell is the Reed-Sternberg cell. It is a large cell with a multiple nuclei or single nuclei with a multiple nuclear lobes with a large inclusion like nucleoli, and then cytoplasm is more abundant. So one more one variant of this is the mononuclear cell, that is called as a Hodgkin cell. It contains a single nucleus with a large inclusion like nucleoli. And sometimes it can go for a apoptotic death, that is called as the mummification. So what is a Lachner cell? This is a cell seen in the nodular sclerosis with a multilobated nuclei with the abundant cytoplasm. When we process the slide, during the cutting of the sections, the cytoplasm will be ruptured and leaving the nucleus is sitting in the halo-like areas. So that is called as the Lachner cells seen in the nodular sclerosis. And last one is the popcorn cells. It is seen in the lymphohistiocytic variant with the nuclei will be seen as a polypoid nuclei with a more abundant cytoplasm. So these are the variants of the Reed-Sternberg cells. Main cell is the Reed-Sternberg cell and variants of this is the Hodgkin cell, Lachner cells, popcorn cells and sometimes mummified cells. So the first picture is the RS cells. Next one is the mononuclear cell. Third one is the Lachner cells. So this picture shows the different variety subtypes of the classical Hodgkin's lymphoma like nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte poor. Coming to the nodular sclerosis, most common type, it contains 65 to 70%. When we see these subtypes, we have to see whether it is associated with the EBV infection, what is the area which is affected, what is the prognosis, organs involved, and how is the morphologically, microscopically it is seen. So coming to nodular sclerosis, it is uncommonly associated with EBV. Male and female is equally affected, and the prognosis is excellent in nodular sclerosis. How microscopically it will be seen means bands of collagen, they will subdivide the tumor cells into circumscribed nodules, and we can see the Lachner variant of the RS cells here. And apart from that, reactive cells like T cells, eosinophils, plasma cells will be seen here. Typical RS cells are very uncommon. Coming to mixed cellularity, it considers 20 to 25%. Here, EBV infection is seen in 70% of the cases, and prognosis is also very good. Here, the diffuse effacement of the lymph nodes along with the merry RS cells, mononuclear cells, and the reactive cells will be seen in the mixed cellularity. Coming to the lymphocyte rich, this is not a common form, and EBV is 40% associated. Prognosis is good, and here we can see so many amount of reactive lymphocytes will be seen here. And coming to the lymphocyte poor type, it is a very less common type, but it contains EBV infection is 90% associated. Older patients, HIV is commonly associated with this stage. and the prognosis is less favorable in lymphocyte poor. So here lymphoid cells will be very less, only we can see the RS cells. So the picture shows the lymphocyte rich. Next is the bands of collagen separating the tumor cells into nodules in the nodular sclerosis. Third picture is the mixed cells with the RS cells. We can see orange color eosinophils in the slide. And the fourth one is the lymphocyte depleted type, showing decreased amount of the lymphocytes. So these four are the classical type Hodgkin's lymphoma. Next to the subtype is the main type is the nodular lymphocyte predominant type. This is the non-classical Hodgkin's lymphoma. Here it is not associated with EBV. It can present with an as an cervical or axillary lymphadenopathy. So the main nodular this type contains the variant known as the popcorn cells along with the reactive cells, dendritic cells, macrophages. Here classical RS cells will not be seen. Other cells will not be also seen here. So this is the picture showing nodular lymphocytic predominant Hodgkin's lymphoma. Multiple nodules, expansive nodules are seen here. So coming to the Hodgkin's lymphoma, we have a staging which is called as the Ann Arbor classification. We have a staging like a stay up to from stage 1 to stage 4 according to the number of lymph nodes and which site is affected, whether it is on same side of diaphragm or both sides, like that we can divide the stage the tumor into 4 subcategories. Coming to the Hodgkin's lymphoma, it produces painless lymphadenopathy and systemic symptoms like fever, night sweat and weight loss will be there. Immune dysregulation will be there. So treatment is radiotherapy, chemotherapy and anti-CD3 antibodies can be given. So this is about lymphoid neoplasms. We have seen NHL, few NHL and Hodgkin's lymphoma. Next we will go to the myeloid neoplasms. So the myeloid neoplasms, they are coming from the hematopoietic progenitor cells. They mainly involve the marrow. The symptoms are mainly due to the altered hematopoiesis. So coming to the myeloid neoplasms, we have 3 subtypes. One is the acute myeloid leukemia, next one is the myelodysplastic syndromes, and third category is the myeloproliferative disorders. So coming to the acute myeloid leukemia, it is a tumor of the hematopoietic progenitors due to the acquired oncogenic mutations which impairs the differentiation of the myeloid cells. There will be more amount of immature myeloid blasts. So there will not be maturation, differentiation will not be there. So there will be more amount of immature myeloblast in the marrow. It produces the marrow failures. The age group, common age group is 60 years of age. So coming to the classification of the AML, the WHO classification, new classification subdivides the AML into 4 categories. One is the AML associated with the genetic aberrations. Next one is AML arising with the MDS or it contains MDS-like features. Third category is the therapy-related AML. Fourth one is the NOS, AML NOS. It is classified according to the FAB, previous FAB classification. So this is the classification of the WHO classification of the AML. So first one is the AML with the genetic aberrations. It can be 821 or inversion 16, translocation 15, 17. All these are genetic AML with the genetic aberrations. Next it will be the AML with the MDS-like features. And then third will be the AML after therapy for some other lesions. So the AML is produced after therapy for some other cancers. And then AML not otherwise specified. This is the previous previous FAB classification like one. So here we can according to the differentiation and the lineage, we can subdivide the AML from AML M0 to AML M7. Coming to the morphology, so the main neoplastic cell is the myeloblast here. So matured cells will not be here. So if the myeloblast constitutes more than 20% in the bone marrow, it produces the AML. Diagnosis can be given. So how the AML myeloblast will be seen as? So it contains more amount of cytoplasm. Nucleoli 2 to 5 nucleoli can be seen. The chromatin will be very delicate and the cytoplasm will be containing a fine peroxidase positive azurophilic granules. These atrophic granules, they produce a rod-like or needle-like structures. These are called as the Auer rods. These Auer rods are more common. They are numerous in the acute promyelocytic leukemia. So from myeloid neoplasm, according to the differentiation and the lineage, we have subtypes. So first blast is the myeloblast, and one more blast, it is the, if it is an arising from the monoblastic region origin, that is the monoblast. So this monoblast will be containing folded or lobulated nuclei, and it also contains the non-specific esterase positivity. So if the blast shows megakaryocytic differentiation, that is the AML blast with a megakaryocytic differentiation, these kind of AML, they produce a marrow fibrosis. And then sometimes AML blast can have a erythroid differentiation also, that is a AML M6. Megakaryocytic differentiation is AML M7. So the number of leukemic cells, it can be from a more than 1 lakh, or it can be very less also. What is aleukemic leukemia? If the blasts are not seen in the peripheral blood, that is called as the aleukemic leukemia. So coming to the cytogenetic abnormality, chromosomal translocations or deletions and monosomies, they produce the acute myeloid leukemia. If the patient is a younger age, they are mostly commonly associated with the translocations. If the AML is associated with the MDS, or if it is therapy related, or if it is occurring in the very elderly patients, common mutations like deletions and monosomies will be common here. So the genetic abnormality, it produces the normal CBF1 alpha and CBF1 beta transcription factors. They are required for the normal hematopoiesis. If there is a translocation in 821 or inversion 16, they will be interfering with this CBF1 alpha and CBF1 beta, and they block the maturation of the myeloid cells. Like that, normal RARA is needed for the granulocytic differentiation. Due to the PML RARA fusion, this differentiation will be affected here. And the mutations in FLT3, they produce the increase in cellular survival and proliferation. So these, all these genetic abnormalities, they help in the proliferation of the myeloblasts and other blast cells. So what is the presentation? So usually it is an acute leukemia. So the patient will be presenting within weeks or few months, and due to the compromise of the normal hematopoiesis, the patient will be presenting with anemia, neutropenia, and thrombocytopenia, producing all the symptoms. And then in AML with the translocation 15-17, these patients will be having a bleeding tendency. So infections due to fungus Pseudomonas, they can occur, and these blast cells, they can go on involved in the other soft tissues. Like if it goes in monocytic cells, if they monoblastic cells, they go on infiltrate the skin. That is called as the leukemia cutis. And the monocytic differentiated cells, they will be going and accumulating within the gingiva also. And if the AML is presenting as an localized soft tissue mass, that is called as a granulocytic sarcoma or chloroma. Coming to the prognosis, if the patient is having 821 or inversion 16, they have a good prognosis. If the patient AML is having associated with the MDS or therapy or elderly patients, it contains the bad prognosis. So this is about acute myeloid leukemia. Then we will go to a chronic myeloid leukemia. So the chronic myeloid leukemia is produced by the chimeric BCL-ABL translocation. So the BCR gene is present in chromosome 22 and ABL is seen in the chromosome 9. So these chimeric fusion, they produce a constitutively active BCR-ABL tyrosine kinase, which is a size of 210 kilodalton. So if the BCR-ABL is produced by the reciprocal translocation, that is specifically called as an Philadelphia chromosomes. So BCR-ABL can be produced in some other manner also. So if it is produced by the reciprocal translocation, this is called as a Philadelphia chromosome. So this is the picture showing BCR22 chromosome and ABL in 9 chromosomes. They produce the fusion, BCR-ABL fusion mRNA, producing a active tyrosine kinase. Coming to the morphology of the chronic myeloid leukemia, usually here the marrow will be markedly hypercellular, producing maturing here. Maturation is not affected. BCR-ABL will not affect any maturation here, like AML. So here matured cells can be seen. So maturing granulocytic precursors, eosinophils, basophils, all can be seen in the marrow. Megakaryocytes also increased. Erythroid cells, it can be normal or it can be decreased also due to the hypercellularity. The macrophages, they will eat the apoptotic cells. They produce the abundant wrinkled green blue cytoplasm. These macrophages will contain the green blue abundant wrinkled cytoplasm. This is called as the sea blue histiocytes. When the blast coming to the peripheral smear, if the leukocytosis is exceeding 1 lakh per millimeter cube, uh, this is the common amount of it can go up to 2 lakhs also. So we can see the in the peripheral smear, we can see all the maturation stages of the myeloid precursors from the myelocytes, metamyelocytes, some amount of blast cells, and mature forms like neutrophils and the band forms. All these maturation stages will be seen in the peripheral smear. And usually we have a stages like crisis because stages will be there. This is an chronic or stable phase. This is here the blast will be less than 10%. So this picture shows the all stages of the myeloid precursors. Mature neutrophils are there, granules with the myelocytes are there, band forms are there. So this is the CML. The next picture shows the massive splenomegaly in the CML. So usually fifth to sixth decade will be the age group in serious one. The anemia is mild to moderate due to the increased in the cell turnover, fatiguability, weakness, weight loss, anorexia, all will be there. The spleen will be massive. So if it is in the history, they give massive splenomegaly with the increase in the cell count and our normal platelet count. We have to think about CML. So due to the massive splenomegaly, dragging sensation in the abdomen will be there. Or then splenic infection, pain can be there. After 3 years, if the patient is seen in a stable phase, and after 3 to 4 years, 50% of the patients can go for an next step like an accelerated phase. So in the accelerated phase, anemia and thrombocytopenia will be there. Basophils will be increasing. This is due to the increase in the additional cytogenetic clonal abnormalities. So they increase the stage phase to accelerated phase. So after 6 to 12 months of accelerated phase, these patients can go for a blast crisis. Here the picture will look like an acute leukemia. So the blast crisis sometimes can come without accelerated phase also. So in the blast crisis, 70% of the patients will be having myeloid blast and 30% can have a lymphoid blast. So what is the lab investigation? We can see the molecular genetics, cytogenetics or PCR method. We can see BCR-ABL fusion gene. Coming to the treatment of the CML, so BCR-ABL inhibitors should be used to produce hematological remissions. And if the patient is very young, we can go for a hematopoietic stem cell transplantation. So we have seen about the uh, CML. So the CML belongs to myeloproliferative disorder. So we have 4 to 5 myeloproliferative disorders. Other things are polycythemia vera, essential thrombocytosis, primary myelofibrosis, and then we have a myelodysplastic syndrome. It is a type of a myeloid neoplasm. So here the maturation is ineffective. So the differentiation will be ineffective in a disordered manner. So here the patients will be having bone marrow will be having abnormal cells. The peripheral blood will be having cytopenias. Due to the ineffective cells and disordered cells, there will be more amount of ineffective hematopoiesis. So all the cells, progenitor cells with a disordered differentiation, they will be having apoptosis in the bone marrow itself. So the bone marrow will be hypercellular with the dysplastic differentiated cells. Here the erythroid series will be having a ring sideroblast, myeloid series will be having pseudopelha cells, and the pond ball nucleus will be seen in the megakaryocytes. Coming to the peripheral smear, here pseudopelha cells, chain platelets will be the blast will be less than 10% in the myelodysplastic syndrome. So we will see, we have seen the WBC disorders. We will see some of the RBC disorders. Coming to the RBC, red blood cells, they are the A nucleated cells. They contain the hemoglobin to carry oxygen. So we have different types of hemoglobin during the various stages of our age. We will have different types of hemoglobin. In the adult, what we normally have is the hemoglobin A containing alpha 2 and beta 2, and hemoglobin A2, which is an alpha 2 delta 2. So first disorder we see is the sickle cell disorder. We can divide the red blood cell disorder according to the whether it is a membrane defect or it is an enzyme defect, or according to the it is an hemoglobin defect. Hemoglobin production qualitatively, if it is defected, means it is in sickle cell anemia. Number of hemoglobin production defected means it is in thalassemia, qualitative and quantitative. So first we will see the sickle cell disease. It is an also called as the hemoglobinopathy, hereditary hemoglobinopathy. What is the cause of the sickle cell? There will be point mutation in the sixth codon of the beta globulin. So the glutamic acid will be there normally. Due to the point mutation in the sixth codon of beta globulin chain, there will be replacement of valine in the place of glutamine. So this produces abnormal physiochemical properties to the red blood cells, producing sickling of the red cells. So this picture shows the normal hemoglobin A contains the, it will be having a amino acid, glutamic acid will be there. Due to the point mutation, the amino acid will be going for a valine. So it produces hemoglobin S. This hemoglobin S, when there is an deoxygenation, it will be producing a polymerization of the all the hemoglobin S will go for an polymerization. So due to the polymerization, that will be produced, they produce a linear rod-like structures. Due to this abnormal linear rod-like polymerization of the hemoglobin S, the normal disc-shaped RBCs, they will be changing into a sickle shaped red blood cells. So initially, if there is an oxygenation, it will be, when there is an deoxygenation, the normal cells will go for a sickle cells. When there is an reoxygenation, the sickle cells will retain the normal. With the continuous cycle of this oxygenation and deoxygenation, permanent membrane damage will occur, which will produce a irreversibly sickled cells. So these cells are abnormal cells. So when they are going to the reticuloendothelial system, they will be caught and they produce a hemolysis. And these sickle cells, they contain the abnormal shape. So the normal flexibility of the biconcave red blood cells will not be here. Say they will be occluding the microvessels. So the microvascular occlusion will be seen here. And with the formation of sickle cells, there will be more amount of dehydration with the increase in the MCHC. So what are the factors which produces the sickling? So if the patient is having normal HbA or normal HbF, it will interfere with, along with the HbS, it will interfere with the HbS to polymerase. It will block the polymerization of the HbS. So the normal HbA and HbF, they will reduce the sickling. But if the patient is having HbS along with the HbC, it will produce the more amount of sickling. And then if the patient is if the red cells are containing increase in the MCHC, that is mean corpuscular hemoglobin concentration, if it is increased, there will be increase in the sickling. If the MCHC is reduced, it will reduce the sickling. The red cells contain intracellular pH, decrease in the pH, that is acidosis. It reduces the oxygen affinity of the hemoglobin, so it also increases the sickling. If the transit time of the red cells through the microvascular bed, the transit time is more, it will increase the sluggishness and it will increase the sickling. So more amount of MCHC, increase in the transit time, increased intracellular pH, acidotic pH, all this will increase the sickling. Hemoglobin A and hemoglobin F will decrease the sickling. So due to the sickle cells, they obstruct the microvasculature. They produce the vaso-occlusive crisis, and we have some other crisis also. So this vaso-occlusion, they produce, they when they go and affect the different organs, we have different manifestations. So if they go and occlude the lung, they produce a acute chest syndrome, that is called containing fever, chest pain, cough, like that. So if it the vaso-occlusive is occurring in the bones, it produces the pain in the bones, that is called dactylitis. It is an hand foot syndrome. So in the penis it produces the priapism, in the eye it produces retinopathy, and it can also produce the stroke. So this is then vaso-occlusive or brain crisis in the sickle cell anemia. What is then sequestration crisis? Usually in children, massive amount of sickle cells will be trapped within the spleen, producing sequestration crisis. And hemolytic crisis, some of the factors can produce dramatic increase in the hemolysis. This produces the hemolytic crisis. So aplastic crisis, when there is an infection by parvovirus B19, it will suddenly stop the red cell progenitors, that produces the aplastic crisis. So we have four types of crisis in the sickle cell anemia: vaso-occlusive or pain crisis, sequestration crisis, hemolytic crisis, and aplastic crisis. So we have a, but these sickle cells, they reduce the malarial load in the patients. So it is a protection of the sickle cells in malaria. So metabolically active intracellular parasites, they will be consuming more amount of oxygen, and they decrease the intracellular pH, and they promote the sickling. So these sickled cells will be destroyed in the spleen and liver. So due to the destruction of the cells, the parasitic load will be low in the patients. So what are the clinical manifestations? Due to the chronic hemolysis, patient will be having moderate anemia, reticulocytosis, hyper jaundice, and gallstones. The spleen initially, due to the erythrostasis, more amount of cells are there. There it will be splenomegaly will be there. After that, later stages, and finally in the early adulthood, only the fibrous splenic tissue will be there. All this spleen will be having repeated infarction and fibrosis and shrinkage. The tissue will be going for a fibrous tissue, like that. It is called as an autosplenectomy. Also autosplenectomy is seen in the sickle cell anemia. Due to the occlusions and infections can occur in all the organs like bone, brain, kidney, liver, retina, like that. And when there is a stagnation in the vasculature in the subcutaneous tissue, it can produce a leg ulcers. And the spleen is not there, so immune functions will be affected. So these patients are more prone for encapsulated organism infections, like pneumococcus and hemophilus influenza infection are more frequent for these patients. So coming to the bone marrow, there will be bone marrow hyperplasia, and this bone marrow increased cells, they will destroy, and they will produce a expansion of the marrow cavity, and they will this expansion, they will produce a new secondary newborn formation. So this produces a X-ray appearance of crew haircut appearance in the skull. So the first picture shows the infarction, that auto infection. The spleen will be of a very small size and fibrous tissue, like that it will become. And then the next picture, peripheral smear, shows the sickle shaped regular RBCs along with the sickle shaped cells. And then third test, screening test, it is a sickle solubility test. So the sickle cells will be producing a opaque material, opaque solution. So in sickle cells, if there is sun, the background lines will not be there. In a normal patient solution, background lines can be seen. This is a screening test. And one more test is the hemoglobin electrophoresis. Various hemoglobins will be going to different areas according to the acidic or acid pH. They will be going in a different length. According to that, we can identify which hemoglobin is there. So this is the hemoglobin electrophoresis. So the other screening test is a sickling test by using 2% sodium metabisulfate. When coming to the peripheral smear, we have a normochromic normocytic RBCs along with the sickle cells, Havalcholi bodies. The bone marrow will be having erythroid hyperplasia. So coming to the treatment part of sickle cell anemia, hydroxyurea can be seen. So the next, the sickle cell anemia, it is an qualitative abnormality in the hemoglobin. Coming to the quantitative abnormality, we have a thalassemia syndromes. So we have a normal hemoglobin is hemoglobin A containing alpha 2 and beta 2. When there is genetic abnormality, the synthesis of the alpha or beta globin chains are affected. So if the alpha thalassemia is decrease or loss of alpha production of the alpha chains. So if there is a production defect in the production of beta chains, that is called as the beta thalassemia. It can be beta 0 or beta plus. So this is the classification of the thalassemia. So we have beta thalassemia and alpha thalassemia. In beta thalassemia, beta chains are not produced. In alpha thalassemia, alpha chains are not produced. In beta thalassemia, we have a major, intermediate and minor thalassemia. Coming to alpha thalassemia, we have a silent carrier, alpha thalassemia trait, HBH and hydrops fetalis according to number of alpha chains which are deleted, genes which are deleted. So the mutations can be producing this thalassemia. Coming to the beta thalassemia, the mutations are, it can be a splicing mutation producing beta 0 and beta plus thalassemia, or it can be a promoter region mutations producing a beta plus thalassemia, or it can be a chain terminator mutations producing a beta 0 thalassemia. So in thalassemia, the alpha chains and beta chains, they are combining. So in a normal patients, normal erythroid cells, alpha 2 and beta 2 are seen. In a thalassemia, beta globulin chains are reduced. So there will be excess amount of alpha globulin, which are seen as an insoluble alpha globulin aggregate in the red blood cells. So these are erythroid precursors. So these abnormal erythroid precursors, when they leave the blood, they will be trapped in the reticuloendothelial system. These alpha aggregate will be taken as an this will be taken up by the spleen cells, and it will produce a extravascular hemolysis. These abnormal cells, due to the abnormal hemoglobin amount, these cells will be going for an ineffective erythropoiesis. That means apoptosis, death of the erythroblast within the bone marrow. So due to this, more amount of anemia will be there. Due to anemia, it will produce a tissue hypoxia. Due to that, erythropoietin production will be more. This erythropoietin production will produce more proliferation of the more amount of erythropoiesis. So marrow expansion will be produced here. Due to the erythropoietin increase, there will be more amount of, there will be systemic overload. Secondary hemochromatosis will be seen in the patients. So the beta thalassemia major anemia is by, one is by the deficit of the hemoglobin A synthesis, and also there will be RBC inclusions. What is ineffective erythropoiesis? The erythroid precursor cells, they go apoptosis within the bone marrow. That is called as the ineffective erythropoiesis. So when we see the peripheral smear in the thalassemia patients, there will be more amount of anisopoikilocytosis, microcytic hypochromic anemia. So what are the three major microcytic hypochromic picture producing diseases? One is the iron deficiency, next is the beta thalassemia, third one will be a sideroblastic anemia. So here we can see a microcytic hypochromic blood picture. Along with that, target cells, basophilic stippling, and nucleated red blood cells will be seen. It is an hemolytic disorder producing increase in the reticulocyte count. When we see the bone marrow, there will be expansion of the bone marrow due to the increased hematopoietic cells. So coming to the anemia, here the anemia will be manifesting after the cessation of the HbF production. So HbF will be switching into HbA. So after 6 months only, the manifestations will be starting. In the thalassemia major, the hemoglobin level will be around 3 to 6 milligram per deciliter. Hemoglobin F will be increased and hemoglobin A2 will be normal or bone. Due to the marrow expansion, there will be cortical bone erosion and new bone formation. It produces the crew cut appearance in the X-ray. And due to the phagocytic hyperplasia and extramedullary hematopoiesis, all the organs like liver, spleen, and the lymph nodes will be enlarged. There will be more amount of destruction. It produces the secondary hemochromatosis, and This hemochromatosis usually goes and damages the heart, liver, and pancreas. So the thalassemia can be prenatally can be diagnosed by the analysis of the molecular analysis of DNA. The treatment will be transfusions and repeated blood transfusions and iron chelation to reduce the hemochromatosis manifestations. And bone marrow transplantation is the cure for these patients. So this peripheral blood picture shows the beta thalassemia with a target cells and microcytic hypochromic red cells. This X-ray picture shows the crooked appearance in the skull. Coming to the beta thalassemia minor, it is an heterozygous disorder carrier having a normal beta and along with a beta plus or beta 0 allele. So these patients will be having a mild anemia and they will be usually asymptomatic, and peripheral blood will show microcytic hypochromic anemia along with target cells and basophilic stippling. The disease bone marrow will also have mild erythroid hyperplasia. Next is the alpha thalassemia. Alpha thalassemia is due to deletion of the alpha globulin chains. Number of alpha globulin chains affected, we have a different subtypes. So this is a silent carrier. When there is an one alpha globulin gene deleted, so that is called as a silent carrier. It is an asymptomatic one. And if there is an two globulin genes are deleted, that produces the alpha thalassemia trait. It is a milder anemic one. Third one is the hemoglobin H disorder. In a older children and adult, when there is a more three globin genes are deleted, it produces the HbH. It is an the anemia will be moderately severe. And the fourth one is the all the four alpha genes are deleted here, so it is in most severe forms. So usually in the fetus itself, the uh, fetus will be manifesting the symptoms. So the fetus will be having severe pallor, generalized edema, massive hepatosplenomegaly. All this will be seen in the fetus. So life, the patient will be, the fetus sometimes it can go for an IUD also. So this is about thalassemia, alpha and beta thalassemias. Coming to an hereditary spherocytosis. Hereditary spherocytosis, it is a disorder of the membrane. So the normal membrane, red blood cell membrane, it will be having a, for stability, it will be having a cytoskeletal structures with the proteins. The main proteins are horizontal and vertical proteins are there. The horizontal protein is the spectrin, and the vertical proteins like band 3, protein 4.2, protein 4.1, actin are there, and glycophorin are there. So any of these any gene mutations affecting these production of these proteins, they will destabilize the RBC membrane. So the normal flexibility of the RBC membrane will not be there. The when due to the abnormal protein production, when these RBCs, when they go through the small tiny sinusoids, the flexibility will not be there. So small amount of membrane will be lost during each passage. So due to this loss of the membrane, there will be decrease in the surface area and more volume will be there. So surface area to volume is deranged, which produces the spherocytic shape of the normal cells. So the normal disc-shaped RBCs, which are due to the loss of membrane progressively, they attain a spherocytic shape. Due to this spherocytic shape, when they go for they enter the reticular endothelial system, they will be hemolyzed there. Extravascular hemolysis in the spleen will be occurring there. So this membrane defect produces the loss of membrane with the splenic trapping and phagocytosis. This is the extravascular phagocytosis. So this peripheral smear shows the dark cells without any pallor, dark spherical shells. These are called as the hereditary spherocytic cells, spherocytes. Small Howell-Jolly body inclusions are seen in the cells. So these patients will be having spirocytes along with that anemia due to the extravascular hemolysis and more amount of trapping of the cells. That will be splenomegaly, and due to hemolysis, jaundice will be there. We have two type of crisis here: aplastic crisis due to acute parvovirus infection and hemoglytic crisis due to intercurrent events. They produce two types of crisis in spirocytosis. Due to the more amount of destructions, there will be pigment gallstones, and we can test these spherocytes by osmotic fragility test. When we put the cells in the hypotonic solutions, the cells will go for a hemolysis. So this is osmotic fragility test. So what is the treatment? Splenectomy usually treats the anemia and its complications. So splenectomy, we can do splenectomy for these patients. The next disorder is the aplastic anemia. Here the hematopoietic formation, it is a chronic disorder producing primary hematopoietic failure. So these are the major causes of aplastic anemia. It can be either it can be an acquired one or due to the chemical agents and physical agents, irradiations, viral infections, or drugs. All are inherited disorders like Fanconi's anemia, telomerase defects. All these produce a aplastic anemia. So the stem cell will be due to the environmental drug, factors and other genetic abnormalities. So they will produce a genetically altered stem cells. So the proliferation and differentiation of the cells will not be there. So it produces the marrow aplasia. In aplastic anemia, pancytopenia, all the lineages will be reduced. And the reticulocytes will be lost in the aplastic anemia. When we see the bone marrow, there will be hypocellular bone marrow. Hematopoietic cells will not be there. Only fat cells, fibrous stroma, and scattered lymphocytes and plasma cells will be seen. When we do a bone marrow aspiration, we will not get any material. This is called as the dry tap present in the aplastic anemia. So next is the megaloblastic disorder, megaloblastic anemia. Megaloblastic anemia is mainly produced due to the deficiency of the vitamin B12 or deficiency of the folate. So these they produce the impairment of the DNA synthesis. So immature maturation defect in the DNA nuclear that leads to ineffective hematopoiesis. So these are the causes for vitamin B12 and folic acid deficiency. Coming to the peripheral smear, these patients will be having macrocytic. The red blood cells in the peripheral smear will be macrocytes or macroovulocytes, and reticulocyte due to the decrease in the production, it will be there will be a decrease in the reticulocyte, and neutrophils will be showing a nuclear hypersegmentation. When coming to the marrow will be showing marked hypercellular due to the erythroid hyperplasia, and some amount of dysplastic cells will be there, and nuclear maturation will be delayed in the megaloblastic anemia. In the granulocytic precursors, due to the dysmaturation, there will be giant metamyelocytes and giant band forms, and megakaryocytes will also have a abnormal bizarre forms. Due to the defective DNA synthesis, these precursors they will go for a apoptosis. This is called as an ineffective hematopoiesis. So the marrow cells will be more, they will go for an apoptosis. Due to that, peripheral blood will be having a pancytopenia. One special type of this is then pernicious anemia in a vitamin B12 deficiency. This is due to the autoimmune attack on the gastric mucosa. So there will be atrophic gastritis. So due to the atrophic gastritis, vitamin B12 intrinsic factor will not be produced. So due to the lack of intrinsic factor, the vitamin B12 absorption will be affected here. So these patients will be having a beefy tongue appearance, atrophic gastritis, and a central nervous system symptoms, and a CNS symptoms. All these will be manifestations in the pernicious anemia. So last one is the iron deficiency anemia. So we have an iron deficiency anemia produces microcytic. It is an microcytic hypochromic red cell anemia. So we have to see the normal iron regulation. Usually intestinal absorption will be producing a plasma transfer in iron. These transfer in iron will be used for production of the erythroid precursors, and it will come for circulating erythrocytes. After 120 days, these erythrocytes will die, and this will be taken up in the mononuclear macrophage cells. These cells will be destroyed, destroying the RBCs, and they give the plasma transferrin iron. So this is an cycle like one, and sometimes this iron will be shedded in the mucosa of the skin, gut and endometrium, skin cells and gut and endometrium. So how the iron is absorbed in the food? So we have an animal iron, from the animal foods and vegetable foods we have an heme and non-heme iron. So the heme iron is the Fe2 plus form and the non-heme iron is the Fe3 plus form. Fe3 plus form has to be changed, converted into Fe2 plus form for the absorption in the duodenal cells. So if it is an Fe2 plus form, then only it can be absorbed from the absorbed in the duodenal enterocytes. So the normal initial will be Fe3 plus will be converting into Fe2 plus by the duodenal cytochrome B. Then this Fe2 plus will be taken up inside the enterocyte by the DMT1 protein channel. In the cytoplasm, Fe2 plus through the ferroportin, they will be going out of the enterocyte into the blood. In the basolateral side, one more hepastine protein will be there. This will convert Fe2 plus into Fe3 plus, and this Fe3 plus form is seen in the blood vessels. So this will be combining with the plasma transferrin, and it will be going to all the erythroid marrow cells and the liver, like that areas. So this is the absorption of the iron. So if there isn't any deficiency in iron, due to any dietary lack or impaired absorption or increase in the requirement or chronic blood loss, this will produce a iron deficiency, microcytic hypochromic iron. Coming to the morphology, as I told, it will be a microcytic hypochromic anemia, and in the bone marrow there will be increased amount of erythroid to compensate the anemia. There will be increase in the erythroid progenitors. So in marrow, there will not be any stainable iron. So we can use a special stain, Prussian blue stain, to see whether any iron storages in the macrophages are seen or not. So the patients can manifest a koilonychia, alopecia, atrophic changes in the tongue, and atrophic gastritis, intestinal malabsorption symptoms can be there. Or if the iron is depleted in the central nervous system, the patients can have a manifest a pica, which is a clay cravings. So one more thing, if the patient is having a esophageal web along with microcytic hypochromic anemia and atrophic glossitis, this is called as the Plummer-Vinson syndrome. So in iron deficiency anemia, hemoglobin is less, hematocrit is less, serum iron and ferritin level are low. The total iron binding capacity will be high. Iron saturation is less than 15%. And reduced iron source, they decrease the hepcidin levels. So hepcidin level will also be low only. So this is about the iron deficiency anemia. So coming to the anemia, we have two types of major classification. Either it can be a morphological classification or it can be a etiological classification. Coming to the morphological classification, we have to see what is the morphology. According to the MCV, we have to subdivide this as an less than MCV less than 80 femtoliter, we can tell it is a microcytic hypochromic anemia. Or if it is in microcytes, or MCV is 80 to 100, we can tell it is a normocyte. Or if it is more than 100, then we can tell it is a macrocyte. So the cells, according to the size of the cells, it can be a microcytic hypochromic anemia or normocytic normochromic anemia, or it can be a macrocytic anemia. One more classification is etiological classification. Etiological classification, it can be due to the acute blood loss, or it can be deficient production, decrease in the production, or it can be due to increase in the destruction, which is called as the hemolytic anemia. So it is a fast revision. Not all the points are not covered here, and all the portions are not covered here. Hope this is useful for you. Thank you.
ஹலோ மேம்.
Hello.
நீங்கள் காத்திருக்கலாம் அல்லது
ஹலோ மேம்.
Hello.
எஸ் மேம்,
We
we
can
will end.
close the session, no?
Ma'am, yes ma'am, we will end it with the Shanti mantra, ma'am.
Yes. Ma'am. Hello. Ma'am. Hello, ma'am. Okay, ma'am.
Shanti mantra. सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामयाः, सर्वे भद्राय पश्यन्तु, मा कश्चित् दुःखसुखभाग्। ओम शांति शांति शांति. Thank you, ma'am. Thank you for the session, ma'am.
Hello.
Hello, ma'am.
Ah.
Thank you, ma'am.
Thank you.